epidurals with blocks. We were apprehensive, so of course we used to keep a backup of the epidural catheter and then put out the adductor canal catheters too. If in case the adductor canal doesn't work, the epidural would, right? But then gradually we migrated away from it, but we realized that the posterior knee pain was still a big problem. Then we started a low-dose, very weak drug in the sciatic, anterior sciatic approach to cover up the posterior knee. The surgeons were still wanting to give the LIA, so they continued, but gradually we've shifted away from LIA, shifted away from epidurals, and now we do only, and why did we come to geniculars, I'll answer later. So now we do adductor canal catheters for 100% of TKR patients. We also offered them genicular because we realized that 20% of these TKR patients return to us with chronic knee pain, even a month, 2 months later after surgery. And the surgeons actually came to us that, okay, you cover the 5 days fantastically well. Our patients are not on any IV analgesics, they're only on oral multimodal analgesia, opioid sparing and diclofenac free. But what after the month of surgery? What after 2 months of surgery? 20% is a big bracket. It means, 2 out of every, 10 में से 2 patients वापस आ रहे हैं और दुखी हैं कि ये surgery गलत करा ली. So we added genicular nerve block with some additive to cover up a long-term pain management sketch. And we've also given this as a thesis topic to one of the students who's actually attending this workshop today. And we really want to publish this, that in addition of a genicular nerve block, and see at its longer effects on the development of chronic pain development in post-operative knee replacement patients. So that's the...
So that's a rationale.
Yeah, so I just wanted to understand the single genicular nerve block at what time in the intraoperative period?
Pre.
So how
right
it is going to decrease the incidence of chronic pain?
So when I studied the literature, it says that acute pain is actually one of the, so the development of chronic pain in knee replacement patients is a very poorly understood concept. Multiple reasons are around it. So even the gender, they say, the psychology of the tissue trauma, they say. But one of the major reasons which is documented is acute pain. So well-managed acute pain reduces the occurrence of chronic pain. We add steroid to, of course, the local anesthetic that we use for genicular. And that seems to help. It has helped us. We've done it in the last 9 to 10 months. Genicular has become a norm in every knee replacement patient.
So this is pre-op that you give?
In the OT, yes. After induction, after spinal anesthesia.
Immediately after?
Immediately after spinal anesthesia.
So let me be the devil's advocate. So let's understand the origin of various 4 genicular nerves. So superior medial genicular nerve originates from nerve to vastus medialis. If you are doing a good adductor canal block, do we need a SNGN? No. If it's originating from NVM, so why do we need it?
The geniculars will originate from the common peroneal and the tibial.
And I am talking about SNGN, superior medial genicular nerve. Literature says it can originate from 2 sources. One is NVM, the other is tibial. And tibial is very rare, most common is NVM. When we are blocking nerve to vastus medialis in proximal adductor canal, which you agree upon, do we need SNGN? My question is, answer is big no. So we do not need SNGN. Let's come to another one, which is inframedial genicular nerve, which originates from tibial nerve. Do we actually need that? The incision is not going that deep up to inframedial quadrant. I would request my 2 orthopedic surgeons, Dr. Gaurav and Dr. Ankur, to throw a little light on the surgical steps, whether we are reaching to the inframedial quadrant that deep or it's predominantly the supramedial quadrant when we do the medial parapetal arthrotomy. I'm sorry I'm troubling you with these.
It's all right. So our incision, I'll just show it to you on my knee, would start about a handbreadth above. The patella,
yeah.
And we would go down, and we would go down to the tibial tuberosity.
Okay.
And if it's a fat patient, my skin incision would extend a little lower just to put less pressure on the skin.
So thereby implying the skin incision is long, but the capsular incision in the inframedial quadrant is of small size as compared to the supramedial quadrant. So my next question comes, do we actually need a IMGN? I leave it to your discretion. The next question I offer you is, what about supralateral genicular nerve? What is its origin? The common peroneal. So do we need that? If there is not much of tug to the lateral capsule inside the surgical duration, I have all my doubts that we need SLNGN. So I am trying to argue it out on the basis of origin of these nerves, plus the surgical steps. So there's an aggressive group in United States, Jeff Gatson, if you watch his videos, he would say proximal adductor canal or distal femoral triangle plus geniculars plus IPAC, that is their standard. So now coming on to the next question about posterior knee pain. Is it a fact or a myth? The surgeons first. So we have done adductor canal blocks.
Definitely a fact.
Fact. So in your practice, you practice LIA or you?
Leah,
Leah.
I will infiltrate.
Okay, what about your center, sir, in Sancheti?
Oh, there's one surgeon who gives LI to all his blocks, all his surgical procedures. But IPAC we restrict only when there is a posterior osteophytes, when they want to exercise that. Second is, they mention about a tight posterior flexion gap. So is it intraoperative that you look at or in the preoperative? So that's intraoperative. And so these are the 2-3 indications where I would do an IPAC. Otherwise we just, and also a flexion deformity.
So which IPAC you prefer, the proximal IPAC or the distal IPAC?
No, we prefer the proximal ones.
Okay, so now coming on to a beautiful cadaveric dissection where they have displayed the proximal versus distal IPAC. Proximal would take care of the SMGN in 100% of the patients. Distal would take care of the SLGN in 100% of the cases. So if I have to choose between proximal and distal, my personal take would be distal because I am getting additional SLGN block. Whereas supramedial genicular is originating from NBM. In any case, whether I do a distal femoral triangle or a proximal adductor canal, I would be taking care of. So that was my take. I'm not sure whether I have convinced you or not. It's entirely up to you. What about Dr. Manish? So what he thinks of posterior knee pain?
Nothing.
So knees are the commonest surgeries which we do. I think that is what.
Posterior knee pain on day 1 or the day 2 of the surgery, sir.
So he's a smart man. He's trying to question me. मैं सूत्रधार हूँ, मुझसे question मत पूछो.
The blocks that we are discussing today in this forum are only for the first 24 hours. So posterior
Carrying forward, so how do you take care of the next 24 hours? Do you believe in single shot blocks or you believe in catheters?
I believe in catheters.
Okay. What about house? What is the opinion? Single shot, how many of you are in favor?
For TKR, catheters.
Yeah. No, single shot, only 3. What about rest of the people, they are favor of catheters? Yes, so good number of people are in favor of catheters. If you read the prospect guidelines, what do they say? Single shot. Okay, there are many centers in Max, Dr. Shamik works, where they practice single shot and I think in the evening they mobilize. So I would like to know from our orthopedic surgeons, what is your view on outpatient total knee replacement which is happening aggressively in United States? That means early morning you operate and by evening you are discharging them back to home. Do you think it's happening in India? Is it possible in our country or we do not need this?
No, I'm not in favor of this.
Okay.
There's a lot of this patient, the scenarios are so different. You cannot, for a joint like knee with such innovation, extensive procedure, discharge within 24 hours, I think it's not justified.
Okay. So Dr. Gaurav, any
I
take on?
totally agree with what you've said.
Okay.
See, the problem with knee replacement is that the complications, if they come, they usually come on the 2nd or 3rd day.
Yeah.
So I don't like my patients going home before the 3rd day. Most of my patients go home on the 3rd day, which is still a huge step compared to 20 years ago when I started my joint replacement practice.
It was 7 days, I think.
It used to be 10 days. Intravenous antibiotics and all that.
Yeah,
So,
bilateral 7 to 10 days and 5 days for unilateral.
and what they do in the US is they will go from the hospital to a step-down facility. They don't go home. They are going to a early rehab unit, which is like another hospital. And for them, I can understand because the insurance companies want to bring down the cost. So a hospital bed is a little more expensive than a step-down bed.
And also, our patient population is very different.
Very
The kind of patients who are coming to us, I think they are older, much more deformed, and TKR surgery, I realized in our experience, is a festival that the entire family is celebrating in the hospital. They don't want to go home the same day. They really want to stay in the hospital for
Totally.
yeah.
So
It is a task for me to convince
Yeah.
them to go home even on the
On the
3rd day.
3rd day, no, they want to stay an extra day all the time.
absolutely.
So yeah.
So what is your view, sir? In Sancheti Hospital, any outpatient joint replacement
No,
experience?
not yet, no.
Not yet. Okay. Anybody outpatient Yes, Dr. Shamik, would you like to share one or your thoughts on? Oh, I'm talking about unilateral. Okay, this brings.
This is actually like mobilizing on the first day. It's not about outcomes, it's about ego. I want to prove how big a surgeon I am.
So I think we need surgeons like him in our vicinity. So coming on to the last question, okay. So what do you think, Dr. Manish, is the role of anterior femoral cutaneous nerve blocks in this current day era where we are practicing either distal femoral triangle or proximal adductor canal blocks? AFCN. Your slide showed AFCN.
Maybe for the first 24 hours, definitely after giving the adductor canal, we are giving a local infiltration over the sartorius muscle. And the role per se, I don't know because, the thing is quite simple. First 24 hours or after 24 hours,
Manish na mera test le raha hai.
Sir, I'm not taking the test. Basically, in our center practically, sir, we charge for our blocks. We charge for our blocks. So if and we, we are in a practice where we are putting in a catheters and we attach the PCA pumps and we charge for the PCA pumps, and 2 to 3 day cost for that PCA pumps is 22,000 to 25,000 rupees. So the surgical teams want, Dr. Sahab, आपने 25,000 रुपये ले लिए, आराम तो मिला नहीं. So, we have to be, मतलब हमको तो आराम देना है sir, चाहे आप 2 ब्लॉक एक्स्ट्रा लगा दो.
Sir, what is your view on AFCN block?
Yeah, they are required.
Yeah.
Basically, because we have certain patients where we compared just what I demonstrated right now, just the adductor canal block without we can see on the top of the sartorius, you can see the medial cutaneous nerve. And if you go still more lateral, you can see the intermediate cutaneous nerve as well.
Go more medial MFC and
More lateral we come with
IFCN.
IFCN you can.
Yeah.
If you can block these nerves, patient complain of burning pain in the immediate post-op period. So once that is done, it acts as like a rescue block.
Yes. So what we have observed in our clinical practice, previously I was not doing these AFCN blocks. So once you are through at the proximal adductor canal level, just go to 2 to 3 centimeters proximally. On the top surface of the sartorius, you see the triple FT, flat fat-filled triangle. If you just deposit 3 to 5 mm, that will take care of the intermediate femoral cutaneous nerve. But you have to go a little more medial to catch hold of the MFCN. So that's all from my side. I think I would like to thank my panelists for contributing immensely, and Dr. Manish as well as Dr. Diwan for giving us a very good insight on the complex innervation of the knee. Thank you very much.
Can I also request Dr. Divesh, Dr. Manish and Dr. Diwan to kindly help us felicitate our panelists, Dr. Gaurav Rathore and Dr. Ankur Das.
बड़े लोग जो बोल गए उसको सीरियसली नहीं लेते हैं. एक एक करके सर, एक एक कर लीजिए, एक एक कर लीजिए. ये किसका है? हाँ तेरा है. आप ही दे दीजिए. सबसे बढ़िया तो यही है. आपसे बढ़िया और कौन है?
ये तो कह रहे थे कुछ नहीं है, यहीं जहाँ एडक्टर कैनाल डालते हैं वहीं पे थोड़ा ऊपर जाना है, थोड़ा साइड.
Thank you, everybody. Can I request all of you to please come up on the stage, the faculty
Delegates, everybody.
and the delegates,
We can have a group photo.
for a group photograph.
Whoever are available. So it feels really nice. I think after a long day, when you have this level of discussion, and we are still laughing, I think probably it's a good discussion we're having. I mean, it's a very good, I am really happy about the level and the enthusiasm of the persons who are staying here. I can understand it's a very far up place, people have to go back and everybody have kids or something or the other and it's a weekend. But भाई फंक्शन तो वीकेंड में ही होगा, किसी भी आप देख लो वीकेंड में ही होता है, मिडिल में तो कभी नहीं कोई कर सकता है, पॉसिबल ही नहीं है. बट एनीवे, थैंक यू एवरीवन एंड प्लीज कम ऑन द स्टेज फॉर ए ग्रुप फोटो एंड देन वी कैन डिस्कस. टुमारो वी स्टार्ट शार्प एट 8:15, सो यू शुड बी देयर शार्प. सर एक बार सर एक फोटो कर ले प्लीज, एवरीबॉडी कम आ जाइए. And we have a very good performance also, dinner also, drinks also, so stay put and enjoy. Sir,